So welcome to this very, very special episode of Menopause Conversations. My name is Samantha King. I'm a workplace menopause coach and consultant. I'm an executive performance coach as well. And I'm delighted to have my really special guest here today for our special episode, which is on World Menopause Day, Vikram Talaulikar. Have I said your name correctly, Vikram?
Yes.
Brilliant. Brilliant. So let me introduce Vikram because he has an impressive set of titles after his name, and then rightly so, I might like to say. He's a specialist in reproductive medicine at University College London Hospitals, and he's honorary associate professor in women's health at UCL. So welcome, Vikram. For those of you that have never come across you, and I don't know where they will have been, under a rock somewhere, because you are such a great spokesperson for menopause and women's health, tell us a little bit about why you're in this space. And I don't mean why academically, just spiritually, soulfully. Why are you in this space helping so many people navigate menopause and women's health issues?
So first of all, thank you, Amantha, for having this podcast with me and choosing a right theme, because cardiovascular disease, of course, is going to be talked about as part of the IMS theme for the year. And the whole next year, we'll be talking a lot about heart disease in women in midlife and menopause.
Yeah.
To answer your question specifically, I just like doing that. There's nothing else other than that. Somehow, after my training in gynecology, I got driven towards women's health, repromed, and then within reproductive medicine, somehow things aligned that I got more and more interested in post-reproductive health, menopause, and what I do is because of that. So here I am.
I mean, it's amazing. I'm still working on a concept to replicate you, Vikram. I say that every time I speak to you, because we just need to take Vikram and just double him, triple him, quadruple him, and plonk him all over the world, because I think things would be a lot better. So let's get into this very important topic. You're absolutely right. The International Menopause Society has deemed that this year's theme will actually be cardiovascular disease. So what is cardiovascular disease?
So cardiovascular disease, mainly we are referring to changes that happen to the heart, to the blood vessels, because of the aging process. And in the sense, in specifically aging process, I'm talking about the stiffness of the vessels, the lipid plaques that build up in the blood vessels, the changes to the heart, the building up of plaques in and around the heart and blood vessels that then decrease the function of the pumping of the heart, increase your blood pressure because of the stiffness of the vessel. And then eventually those plaques may break, the blocks in the blood vessels may happen, and then the blockage of the blood supply will cause what we call as heart attack. And then heart attack simply means your heart muscle is damaged. And of course, you can die because of that. More likely, you can have long-term problems such as heart failure and the damage that's done to the heart muscle. That's mainly the ischemic heart disease, IHD, or coronary vessel disease. That's really the main point here that changes in and around menopause. There are other forms of heart disease, and some of them do link to hormones in midlife, but we'll probably focus less today because of the time limits and the main focus being on the ischemic heart disease today.
Absolutely. And so we almost, I mean, I used to work in the pharmaceutical industry selling and talking about high blood pressure, which is a silent killer. Often, so many of us are walking around, we don't even realize we have high blood pressure. But for those people who maybe don't have a medical background, or just for a bit of a refresher, it's almost as though we're dealing with like your central heating system in your house. You know, your heart is a pump, and it has to move blood around the entire system, including your brain. So what we need to understand is, where do the problems crop up when we try and connect the dots between midlife and menopause, so the 3 stages: perimenopause, menopause, postmenopause, and obviously cardiovascular disease. So can we start at the beginning with that? I mean, what's generally happening to people in their 20s and 30s if they are averaging, like most people, they've got reasonable access to their sex hormones? What would we be seeing the positive effects of their hormones? What would we see?
So throughout the life, until you get to midlife, or say 45, 50, this is when one would expect most women to go through perimenopause or menopause. Before this time comes, in 20s, 30s, 40s, the key hormone that's kind of driving or putting down your risk of heart disease is the estrogen. The estrogen, in the main form of estradiol, and there are other forms, estrone, estriol, It's basically trying to keep your bad cholesterol low. It's keeping your LDL cholesterol low. It's keeping your triglycerides low. It's keeping your blood vessels very supple. It's preventing the stiffness of the blood vessel. It's preventing the fat being accumulated in the blood vessel, the process we call atherosclerosis. It's keeping your heart pumping well. And all those factors mean normal blood pressure and very low risk of heart disease. And that is what is typically a key feature of estrogen hormone in women, which is why the rate of heart disease or heart attacks in women until they get to 45, 50 is much lower than in men. Even when you look for comparisons of lifestyle and many other factors, which can always have a big influence on these, but like for like, women will always be more protected because these hormones make the difference.
So we know that it's estrogen because that's the thing that's different largely between men and women. So that the estrogen is having a cardioprotective effect. Are we able to say that?
Absolutely.
Okay, so that's really powerful then. So we know that estradiol, that's that E2, and that's the form that then appears in HRT, hormone replacement therapy. Okay, so now we've got a link. Okay, so once we know we've got that protection, I'm very keen to also not miss out Cinderella's other sister, which is progesterone. I mean, what effects does progesterone have in terms of our cardiovascular system?
So again, progesterone is comparatively less studied hormone, but it certainly affects many, many parts of the body much more than we understand right now. It certainly seems that main effect of progesterone, of course, is geared by nature towards periods, towards fertility, towards pregnancy, but it affects almost each and every tissue in the body. There are a number of receptors, including cardiovascular system, which has progesterone receptors. And the progesterone is thought to synergize effects of estrogen, although the effect may be very, very little and low, and estradiol is the main hormone that's linked to heart. It seems to have some impact on helping estrogen achieve its effect on cardiovascular system.
Yeah, and you're right, because there isn't a lot of evidence. I did see some evidence talking very broadly, saying that micronized progesterone does have the ability to lower LDL, so the bad cholesterol, and through pathways, it's also able to increase HDLs, those high density lipids, which is our good cholesterol. Because I think, can we just pause on that for a minute? Because we often have this conversation, people think cholesterol is bad, all cholesterol's bad. And that's not true, is it? So can we just join the dots for people to tell them, where does cholesterol come into sex hormones? I mean, I know, but for people watching, why is cholesterol so important in a topic of conversation like menopause, midlife?
Cholesterol is really important because cholesterol is of two types. You've got the LDL cholesterol, which is the bad cholesterol, and you've got the HDL, which is the good cholesterol. And in fact, it's the good cholesterol HDL, which is linked with better heart outcomes, keeping you healthy. And the way the fat in your body and the fat globules and the metabolites that are generated after you have your digestion, the way they are transported in the blood, and then they get into liver, they get into adipose tissue, they get into heart, into blood vessel, that is actually being regulated by the amount of HDL, LDL. So where you put your fat, whether it's good fat, bad fat, if you have high HDL, anything that improves your HDL, you're likely to do better. Anything that puts up the bad cholesterol, the LDL, more lipid floating in your blood vessels, more the fatty plaques, that's bad for you. HRT, or in general, naturally estrogen, and to some extent, as you pointed out, progesterone, the natural micronized. I'm not going to say about other synthetic ones.
No.
But of course, these ones are going to be helping to pump up your HDL. That's why the atherosclerosis is less. They'll try to suppress your LDL. Some form of estrogens will also suppress your triglyceride, which is again the fat in the circulating blood.
Yeah.
That's why they are cardioprotective.
Yeah. Just to say, when I was working, I was very lucky to go and see cardiac surgery when I was a hospital representative, and I would love nothing more than be gowned up and invited in. And I always remember a consultant saying to me, if you want to know what an atheromatous plaque looks like, just get a tub of margarine, because it's similar in sort of color and consistency. And that's what we have to imagine. We have to imagine when we're maybe overindulging in things like alcohol, not eating healthily, not exercising enough, that actually that's what we're increasing our risk of, is those globular plaques that just sit in our arteries and can, in the worst case, block them completely, can't they, Vikram?
Correct. So they detach, they break down, they block the circulation, and then you have a heart attack.
Yeah. And if it goes to a small vessel in your brain, then you may have a stroke or something like that, or stroke or something like that. So what should we be noticing? Let's so I think we've covered, we know that estradiol, E2, is protective, so that's brilliant. We know that we need to maybe think about it in terms of not just when we arrive at perimenopause, but what can we do? If you are a younger person watching this video, it's really important that you're thinking about, particularly if you have POI or PCOS. Could you just tell people what's that all about? POI, PCOS, and how does that either increase your risk?
Absolutely. So it's a good thing you're talking about this, because we often focus on interventions when things are going wrong or they're just about to go wrong, which is midlife, 40s, 50s. But by that time, if you haven't really focused on your cardiovascular health, you may have already done a bit of a degree of damage to your health. So it's good that we're thinking about 20s and 30s here first before going to 40s. So before we go to POI, PCOS, a quick word. If you're a healthy person in your 20s, 30s, then there is lots you can start doing at this point. And I don't have to repeat this. It is all over guidelines, all over scientific bodies recommend the same. Start putting in a regime of being physically active, exercise 150 minutes a week. Whether it's moderate, rigorous, then the quantity can be different. But anything that suits your routine, anything that you're likely to do regularly and stick to. Eating healthy right from word go. Even including me, many people now find it difficult to sometimes change diets because we've been used to eating so many unhealthy things over the years. But if you put in your diet in a healthy way right in the beginning, you're more likely that you can just stick to it even in your 20s, 30s, 40s,
True.
rather than having to change, look back and do big changes to your diet later on. So diet, exercise, sleep. For young people, again, this is a problem because there is so much technology, so much internet, so many mobile devices. Trying to get that 7 or 8 hours uninterrupted, no mobiles, again, that's stress reduction. Trying to reduce stress. So trying to do everything you can, a small bit of meditation, mindfulness, go and talk to somebody, take a walk in nature, anything that would put your stress down. So all those 4 really will be the key right from 20s, 30s, 40s, alongside your hormones helping you. And when you get to 40s, 50s, you will reap the benefits of what you have done in the last 2 decades. Because even though the estrogen hormone will decline, there are other things you can do then, but you've already built up a very robust non-hormonal sort of lifestyle base, which you can build upon.
Can I add something else in? Only because
Absolutely.
I know I talk about it all the time. Stress.
Yes.
And that covers all the things that you've sort of said, because we know, and this is, maybe we've done a few videos on this, but when you're stressed, your body goes, let's make a choice. We can't be making sex hormones and stress hormones. So let's prioritize on the stress hormone. So we know cortisol goes into massive production, and it's got a nasty habit of hanging around for a long time, that cortisol stuff. It can be 3 days. So that can make you sleep deprived. It can make you less motivated to exercise. You're more likely to focus on the takeaways or things that aren't helpful to you but very easily accessible. You might lean on alcohol a bit more. You most definitely may go for more caffeine, and all of this just compounds all of that, doesn't it, Vikram?
Absolutely.
And
Absolutely.
I think one of the things that we maybe don't focus on, and it's certainly a passion for me, is we need to encourage people to have a healthier relationship with their stress.
Very true. Very true. Stress is a major key.
It's massive, isn't it? And if you are stressed out 20 something, you just bring a lot of those stress habits with you throughout your life, and you never really address them. So all of those things, I think, are so powerful that you've said, and actually that is really important that we've touched on that. So how does that, so let's say you're doing all of those things, but then you still notice there's a reason to come to your clinic and you are being investigated for POI or PCOS. What are those things about?
So the conditions for women specifically, which kind of set them apart from men in the journey towards getting to heart disease, of course, is they could have POI. So 1% of population, 1 in 100 women, could suffer from early stopping of ovarian activity. They go through menopause below the age of 40. That's premature menopause, or POI. And of course, about 10% of women will stop their ovarian activity between 40 to 45. So that's early menopause between 40 to 45. About 10-15% of women have PCOS, that's polycystic ovarian syndrome. This is when you have a large number of follicles or eggs in your ovary, and you tend to produce more hormone, more of androgen, male pattern hormone, testosterone-like hormones.
Okay.
And so in all those conditions, there is an increase in risk of heart disease. Now, it's easy to understand why in premature menopause or early menopause, you would have that risk because, of course, estrogen is gone. Your ovaries are not making any estrogen. So you start steadily seeing an increase in bad cholesterol. You start slow increase in sort of propensity of having diabetes, high blood pressure creeps in. And then you see that these women at a younger age will be affected by heart disease. So the kind of 20 years are lost. Instead of having this in 60s and 70s, they're going to have it accelerated 20 years earlier in their late 40s or 50s because they have lost estrogen much before, a decade or two before they were destined to have menopause. Now, POI on its own is a separate topic. Of course, there are causes, there are reasons it happens, and you manage it with HRT. But the important bit is recognizing it. So somebody who has early menopause, somebody who has premature menopause, what we say now is there should not be a delay in diagnosis. So for women, the key thing is if you've stopped your period, you've had a sudden gap in your periods more than 4 months, don't wait. See your healthcare professional and they'll do a simple set of bloods to know, are you at risk or are you going through premature or early menopause? You will get some indication of it. It may not be because there are many other reasons why you may not have your periods. But it's important to know that things are okay, because if you have suddenly had a gap of more than 4 months when you were not expecting it, something is not correct, and that's causing the periods to stop. So delayed diagnosis is something that we get frustrated with. Is not just women not seeking help, but sometimes women will seek help, but the healthcare professionals may not think about menopause, and they may say, no,
that
you're
whole
too young.
Not joining the dots, is
Correct.
it? It's like
Correct.
like we said right at the beginning of this conversation.
Correct.
So can I ask, only for my own curiosity, because I sort of went down this road myself, because when I was 36 with my 2-year-old daughter, I was having all these symptoms, and so one of the tests they were looking at for me was my follicle stimulating hormone, which was off the charts. Is that the sort of thing that you tend to look at? Because people will ask me, so it's better that you say it now.
Yes,
what sort of things
course.
do people look, what in a blood profile, what are you looking for?
So you're looking for lack of estrogen, which cannot be explained by something else. So estrogen will be low when the ovaries are not producing it, unless you're taking a hormone medication or unless there is any other hormone problem that would cause it. So estrogen being low and the FSH then starts going up, as you rightly said. So raised FSH, low estrogen, something is not right. You need to do either monitoring for some more time, or it may be that this is the early stage of premature menopause.
Well, I can't tell you how many, I did a bit of filming with the company this week because of the work we've been doing there. And I can't tell you how many people have said how helpful these videos are, where it almost feels like they're having like a one-to-one consultation with someone who's just informing them, enlightening them, you know, and giving them that empowerment to then go to their doctor. So it's wonderful that you're saying that, because actually there will be people who just sort of dismiss these things because they sort of think, we're told that narrative, I'm too young, aren't they? So what we're saying is, no, there are some very clear signposting signals here, which means you need to take action. So that's really helpful. So what haven't we talked about, Vikram, in the context of cardiovascular? What haven't we mentioned now that we should mention?
It's the PCOS and the PIH, the pregnancy hypertension. So again, not just the POI. So POI affects maybe 1 to 2% of women, so not common. But the much more common ones are, of course, the PCOS, which will affect about 15% of women.
Wow.
And the reason here, as I said, is it's the increase in the androgens. It's the changes that happen, such as there is a strong insulin resistance that happens with PCOS. there's a strong risk of diabetes in later life with PCOS. And all that means is that this is going to increase your risk of heart disease. So this partly also boils down to ethnicity. So you see more of this risk in, say, Southeast Asian women, for example, who have more particular certain phenotypes of PCOS as compared to other signs symptoms which you will see in other ethnic populations. But the summary of that is that if you have somebody who has PCOS, they should be on the healthcare professionals' radar. Their blood cholesterol and their diabetic screen has to happen at least once every 2-3 years, because you will be able to pick it up earlier in this particular subgroup of women who are at risk. And the earlier you pick it up, earlier you intervene. Don't let the blood pressure slip. Don't let the cholesterol slip. Don't let the diabetic progression slip. The better you will be able to preserve a good heart and blood vessel. That's why the key is, if you've had PCOS, your GP or your specialist should be really monitoring you every 2-3 years, but that's not being always happening across the country or across the world. That's why, again, talking about this theme is important. And the impact of pregnancy hypertensive disorder. This is something we only think localized to pregnancy. We don't think about it outside pregnancy once the delivery has happened. We often forget about pregnancy event. A woman going through pregnancy will change her whole circulation, her blood volume, the things that happens to lipids, her medications that she was on maybe stopped during pregnancy. All that increases her risk, especially if she has hypertension during pregnancy. That does increase your risk of heart disease in future pregnancy. So appropriate advice, being under specialists who really understand this area of pregnancy-induced hypertension, what damage it has in future, how often should you be monitored? That's really the key we should be focusing on. And future guidelines will hopefully include that. But so far, we haven't done justice to women being monitored appropriately for their cardiac risk who've had these pregnancy-related issues.
Do you know, this is so fascinating, because I spoke to Dr. Alice and Dr. Alison Macbeth from with Sarah Ball Clinic, all of those wonderful ladies, Health in Menopause, they're called. My memory was failing me there. Health in Menopause. And we were talking about breast care, and they said exactly the same thing. So, you know, in terms of breast cancer, you know, often people, it's like, we're dealing with the breast cancer. It's like, actually, you know, we're not dealing with anything else around this person who's currently living with breast cancer. And so it really is important, isn't it, that we travel with our medical timeline, that we empower ourselves to know exactly where we were. I mean, when I think about it now, Vikram, I was always going to have a dodgy perimenopause because I had a really dodgy pregnancy. I was really sick with like high levels of histamine and stuff like this, but actually I didn't know what I didn't know. But now I am aware of that. We should be traveling almost with our own medical passport in our head, shouldn't we? Saying, yes, this has happened to me, that's happened to me, and that's happened to me. So you need to be considering that. But until the systems
That's the power
catch
of
up,
these videos. That's exactly what your videos want to achieve.
Yeah, absolutely. So that we really do think, don't just pass it off as something else or an event, an isolated event. That is going to travel with you. So that is really powerful. And can we just explain again, because I know people will not understand. They'll go, thought they were talking about the heart, now they're talking about insulin resistance. I mean, we know that metabolic syndrome, which is, you know, where your sugars go all awry, your heart, your blood pressure is doing something over here. How do these things join up, Vikram? You know, when we talk about insulin, which is processing of sugars, and the heart, how do those things interact with one another? Aren't they separate systems? I know they're not.
They're absolutely not. I mean, in the sense, if I were to draw a diagram now, I would fill the entire screen with arrows, and this would be that, and that, and that, and that. So it would be a nice textbook diagram. Yeah. But it's such a big, complex system. Human beings are designed in such a way that everything is connected to everything. And so, to summarize, to give a simple answer is what you eat, how it's utilized, whether it's fats or whether it's sugars, how it's utilized in you, what your own individual receptors, enzymes, and sensitivities are, will determine where you eventually put the metabolites or the breakdown products of your food. So if you're insulin resistant, which is one of the typical clinical scenario where your insulin struggles to really utilize your sugars, more and more insulin, less and less effect, the sugar is continuously being pumped into your blood, A lot of it will eventually be stored as fat in your liver. And then a lot of it will also mean that that extra fat, that extra sugar will be increasing your plaques in your blood vessels. So it's all connected at the end of the day. Is if you have insulin resistance, you have familial increased cholesterol, triglyceride, your diet is poor, your exercise levels are not utilizing those metabolites, all that will eventually mean plaques, stiffness, blood pressure, diabetes, heart disease.
Brilliantly put. And that's the whole reason that when we have these conversations, menopause is not just about hormone replacement therapy, is it? It's about lifestyle. It's about how you're living your life, controlling your stress, and all of those things. I'm just looking to see if there's anything else at all that we've missed, Vikram.
So I guess it's presentation.
Yes,
in
great.
the sense that the other bit that's often missed is women may not get the same treatment option early enough during their journey with heart disease or raised cholesterol. So studies, for example, show that women who have familial hypercholesterolemia may be diagnosed later, may be offered the same treatments that are offered to men later. Women who end up with symptoms of heart disease, and they can be atypical for women, not the typical ones which men have. So the typical chest pain in the heart may not happen. It may just be the shortness of breath, some sort of indigestion in the upper tummy. You could have lightheadedness, fatigue, sweating, sometimes pain in arm or back. These are atypical IHD symptoms. Those tend to be a bit more common in women. So when they reach the emergency department, often there is a delayed diagnosis or a misdiagnosis. And that is, again, impacting the outcomes of what happens after women have heart disease. Women who have lots of hot flushes during menopause transition, so they're getting to their menopause transition, lots of hot flushes, seem to also have increased heart disease. So there's a correlation between your vasomotor symptom, hot flushes, and your heart disease rates later on, suggesting that there's a group of women or a subgroup of women who are more sensitive to lack of estrogen. So they have more flushes. So that may be a pointer that you're more likely to see the effect of lack of estrogen on your heart. Now, we need more data, bigger studies on this, but it's a useful marker that if you're more symptomatic, more likely that your estrogen level going down is likely to have an impact on your heart. So your lifestyle, your blood pressure will be more important to look after, given that you're more symptomatic. And then, of course, considering HRT may be one option.
That's so powerful. I've spoken to someone this week who I'm just thinking of uppermost in my mind, who said exactly that, who is struggling still with the hot flushes despite being on HRT. So I'm immediately thinking, I think that person should be back at their doctor and asking for a full review, and probably seeing someone who with a cardiology specialism, because they have that in their family. She told me that this week. So that's really, really powerful. And coming back to that then, because I know people will worry, can you take blood pressure medication at the same time as taking HRT?
Yes. So of course, if you have blood pressure, high blood pressure, you're on either lifestyle intervention or you're taking medication, your doctor may choose to give you HRT, which is a bit more safer than oral HRT. So they may choose patches, gel, spray, implant, or a micronized progesterone capsules for you, which are not linked to increase your blood pressure, or they're not linked to any blood clotting risk. So you'll be offered those first. As long as your blood pressure is reasonably controlled, you can take HRT. Now, you might ask me, what if I have sudden high blood pressure? Then, of course, you can take a break. And that's because the worry for the doctor or your physician is, on its own, HRT is a risk for blood clotting, especially if you're taking oral HRT.
Okay.
If you then have a very high blood pressure in your 160s, 180, whatever, 120, you're adding risk factors there for having a blood clot in the brain or a stroke. So if you're on transdermal, that's not a worry. Even if you have a slight transient high blood pressure, you can take medication, bring it down. You don't have to stop HRT. But if you're on oral HRT and you have a transient sudden shoot of BP, best to have a control of blood pressure first with your medication and then restart it. If it's transdermal, you can continue, but make sure you're making efforts to bring the blood pressure down, because on its own, it's a big risk for your kidney, heart, and brain.
Yeah, that's so important. And it is so important to know that. And we should know, I mean, at this midlife stage, what would is it possible to say what we would consider a normal, healthy blood pressure? I mean, I know you're going to say to me, everyone's different.
Well, I'll give you some figures that might be useful. So this
Yes.
time I'll be a bit more generalized, which sometimes
Okay.
doesn't help, but I'll try to do that. So as a baseline, anything less than 140/90 is good. That's acceptable blood
140
pressure.
over 90 is good.
Yes.
So 140, let's just tell people as well, Vikram, because again, you and I, we sort of know, people talk in a certain language, don't they? What's the 140 over 90? We've got systolic and diastolic. What
Correct.
is systolic? That's the top number. Diastolic
The
the
top
bottom
number
number.
is the systolic.
Yeah. So what are they telling us?
So the systolic is kind of your is kind of based on many factors: your blood vessels, the hormones, your adrenaline drive at the time, your stress at the time. It's like your constant day-to-day blood pressure drive that's happening, and we like that systolic blood pressure to be less than 140. Yeah. So if it's less than 140, reasonably good. Now I'll add something else to that 140 later.
Okay.
If the diastolic is actually the blood vessel health, so if it's the more important than the systolic one, can fluctuate quite a lot during the day, but the diastolic will be relatively more stable. It's actually related to the resistance that your blood vessels are giving to the flow of blood. And we like it to be less than 90 in general for most women or most individuals. The caveat there is this may change. So we just had a discussion a couple of weeks back about what sort of blood pressure should we be aiming for women who are on HRT or off HRT or POI. And the consensus of most blood pressure experts was that we should now be aiming for 130/80. So 130/80 should be the ideal blood pressure, and anything less is fantastic. Anything more, we should try and actually reduce it to 130/80. Now, it's not everyone's cup of tea. There will be arguments for and against this.
Always.
I think most guidelines, most data, most studies are pointing out that lower your blood pressure, less the damage to brain, heart, and kidney over the next 2, 3, 4 decades. In fact, when I asked the question in the interview to the blood pressure expert, what would you keep your blood pressure at? He said, I will go for 128/75 or below.
Wow.
And that's
so,
what I am for.
So it really is. I mean, it's so compelling. I don't know if you've seen Vikram. There's a great series on Netflix. You probably don't have time to watch the television, but it's called The Blue Zones. And
yes, everyone has been talking about it.
Oh my gosh.
It's on my list to watch.
Oh, please watch it, because there are some really fantastic touch points. And it talks about exercise, particularly going up hills. So giving your heart that mini workout. They looked at people who are very, very elderly. You know, these are people in their hundreds nearly, walk uphill to go and say their prayers at the church, come back down, go up again in the evening. And they've literally found that there are 9 key things that exist in these blue zones for everybody, but actually our heart health is so important. You know, we look at the Italians eat more carbohydrate per person than anyone else on the planet, and yet they have higher degrees of longevity. So there is something around how we care for this huge organ which is responsible for keeping us alive, basically. So
Absolutely.
So 130/80, I find that fascinating, but great question to ask the people who were coming up with these sorts of guidelines. 120/75 or 80, that's amazing. So that's brilliant. So I think what the take-home message here is that actually we could still be having this conversation, Vikram, and not be relating it to menopause. Absolutely. Heart health is important for everybody, isn't it? So what we do before all counts. It all counts. We bag it and bring it with us. So if you're 20s, 30s, whatever, watching this, start now. Get those good habits going that you said. Right, you summarize what's the middle bit now then. So if we had to give some takeaways, what do people need to be doing in this midlife stage?
So this is where you arrived with your baggage. And so now what do you do? So you have plenty of options, going back to the sort of drawing board and saying, I will do this now. If I don't have a good lifestyle, the key is exercise, diet, and however amount you keep banging the drum, it's less. You have to realize that although there are options, and we'll talk about HRT in a minute, who can take it, what are the risks, benefits, but I think HRT cannot substitute your lifestyle. It is a very good option. It's a very good tool to kind of reap benefits later on in life for women. But of course, it cannot substitute the basic, most important bit, which is diet, exercise, stress reduction, sleep hygiene. And that really is the backbone of everything else. So if you haven't got that right by now, 40s, 50s is the best time to again start doing that.
Yes.
I myself am guilty. I sometimes am up late night doing things, watching mobiles. I don't have the best diet when I'm traveling, doing conferences. And I pay the price of it sometimes. But within your lifestyle, all of us have very difficult lifestyles, difficulties with doing the right things every day. But little bit every day that you do, think of it. Next time you're taking a latte, next time you're drinking a coffee, next time you're doing something, think of it. Is this going to help me? Yes, no, no, I don't. Yes, move on to something else. Something like that. So keep doing that, reinforcing that message. It may take you 5 years to get to a point to say,
Yes.
I now do the right things. That's better than doing something very rigorously for a month, and by the next month, you've given it up all.
Yeah, it's consistency, isn't it, Vikram?
Yeah. Yeah.
And small gains. Let's not beat ourselves up. Do some, if you can do small things, that's great. Were you going to say something else there? Because I was then going to come on to a group of people, but were you going to say something else there?
So I guess you probably have that as a next question, is what do we then say specific to menopause and HRT?
Yeah.
Yeah. Okay. So HRT has been very popular, and unfortunately, it's one medication which I always say has been the most controversial medication on this planet. It's got its ups, it's got its downs. It was a villain some time ago. Now it's a friend and may turn villain again, depending on how we go from here. It's all in our hands. So why is HRT controversial? What is the link to heart disease? So we said before, once the estrogen levels go down, you're going to be having all these problems with blood vessels and heart. If you take HRT, and we'll talk about two groups here. You have the early menopause POI, premature menopause, and you have a natural menopause after 45, you've gone through a bit of perimenopause fluctuation and stopped your periods. If it's POI early menopause, I would strongly recommend HRT. You must take it until at least you get to 50.
Yes.
Whether you take it after that or not is individual, but until 50, take it, because there is enough observational data we have, which I can put my hand on heart and say, it will reduce your heart disease later on in life. Otherwise, you will have increased accelerated progression of atherosclerosis, fatty plaques, and you will compromise your heart health in your 50s and 60s. So hand on heart, HRT, whichever form suits you, should be in place for POI, premature menopause, or early menopause. Now let's look at what happens if you have perimenopause and natural menopause after 50. Now, if that happens, you can still take HRT. At the moment, HRT is a treatment for menopausal symptoms which are unpleasant. It's not a treatment for heart disease. It's not a treatment for preventing heart disease. It's not a treatment for any other reason. The only reason is to improve quality of life if you're having significant menopausal symptoms. And the reason that's been done that way in the guidelines is because we don't have enough data to say, take HRT as a primary preventative tool just to prevent heart disease, because you have to balance the risk of breast cancer, womb cancer, risk of any stroke or blood clots on oral HRT. That doesn't necessarily outweigh the benefit of preventing heart disease for many women, which is why you can't generalize.
No.
So if you're taking HRT, it will be for improving your symptoms and quality of life. But if you do that for the first 10 years after menopause or below the age of 60, there is clear data, time and again, number of studies which do show that you will decrease your risk of heart disease, heart attack, atherosclerosis, and mortality later in life. Absolutely no doubt about that. It's powerful, it's estradiol, it's going to make your heart and blood vessels healthy, keep them healthy. That doesn't mean every woman has to do it. I have plenty of patients or women in the clinic who say, I don't want it. I will do diet, exercise, my parameters are excellent. I will focus on my lifestyle, and they live long, healthy lives. It doesn't mean you have to take HRT. But remember that if you end up taking it for your symptoms, you will reap the benefits of estrogen on top. Now, The question is, what happens after 60? Can you
That's
take
what,
it?
yes. So if we almost consider it post-menopause, is it okay to
Correct.
say that? So the post-menopausal group, because they often get left out, and I feel I'm going to be in that group myself shortly, Vikram. So I'm going to be waving a flag for post-menopausers. So yes. So what about after 60?
So that's been where there has been a bit of controversy. So
Okay.
initial studies suggested what you referred to previously as timing hypothesis or the window of opportunity.
Yeah.
And it is true. So if you have HRT early on, between 50 to 59 or 10 years of your menopause, you're preventing any changes that are likely to happen by the dropping levels of estrogen. So your blood vessels, heart stay more or less same because they're still getting the estrogen from HRT. And so that gives you the benefit for heart disease prevention.
Yeah.
But let's say you went through menopause, you had nothing for the first 10 years or until 60, then some changes would already have happened to your blood vessels and your heart. So some atherosclerosis, some fatty plaques, some increase in blood pressure, some changes to blood vessel stiffness, that would have happened. If you take HRT now, after 60, for some reason, for your symptom, the previous theory was, it might make your plaques unstable, it might make it dangerous for you. But actually, if you look at the long-term data, the Cochrane, the WHI studies, the other studies that have reported now,
yes,
the long-term follow-up shows you won't have the advantages. They may have gone, but certainly there doesn't seem to be any increase in cardiovascular event or mortality or morbidity related to any heart disease just because you've started it late. So individualizing is important for that small group of women who may still benefit from HRT after 60, starting it late. It doesn't mean you can't take it. You look at your risk factors and you could still take low dose transdermal or body identical HRT and still have benefits for your symptom quality of life. It's a neutral effect on heart disease. Doesn't mean you are at increased risk just because you started HRT later.
I really like that message. I really think that's such a positive message because, you know, people have got books on their shelves, like I said to you, and some of those books are going to be out of date now, aren't they? Because the evidence is that we, thankfully, and because of things like the Menopause Research and Education Fund, of which you're part of, because you know we're desperate to get more data coming through, we're going to be able to say some of these things more categorically, aren't we? So it's really helpful that you're saying that, and I'm not joking when I say that I am actually going to be in that category. So I'm questioning myself, you know, having been on HRT since my late 30s, 40s, I want all the benefits. Who wouldn't? But to know that some of those other horrible symptoms that can plague us as we go through this, our HRT is still going to be helpful. Yes, keep taking it, definitely, if that suits your individual needs. And I really like that part of the conversation, Vikram. It's not a broad brushstroke. You're still an individual and your needs are continuously changing, aren't they? And that's what we must remember, is how you started out in your perimenopause journey is not the same as where you're going to be in your postmenopause journey. So we must be mindful of that. I think now would be a really good time to mention a fantastic booklet.
Yes.
Did you see how I did that? Did you see how I did that? And the menopause, yeah, I know it's subtle messaging, Vikram. I'm all about being subtle. But this is a great booklet for people, the menopause support booklet, and fantastically on page 30-31 there's about long-term health, and it talks about heart health, bone health. Okay, this is fantastic. I'm going to put a link in the comments, but this has been produced by the brilliant Diane Dantsbrink, Juliet Balfour, Mandy Leonhardt, Zoe Hodson and Hazel Hayden, and they have put this together and it's freely available.
Big thanks to them. Big thanks to them.
Big love to the big heart to them, because they've done a fantastic job. So we'll make that available. But this is the point, isn't it, Vikram? There's a lot of misinformation out there. Hopefully this video has cleared up some things. I probably have forgotten to ask you something really important. Have I forgotten to ask you something really important about this before we finish today?
No, I guess it's basically we've covered everything. I think the point here is that is hopefully we've given individuals, people who are listening today, to a bit of a broad overview that your health will change as you approach menopause and the years beyond. It does mean slight increased risk of heart disease because of the way the body is constructed and the changes that happen once the estrogen levels drop. There are many things you can do to protect, preserve your health, mainly lifestyle. And of course, for women who are symptomatic, you get additional gains from HRT. Individualizing is important. Some women may choose HRT, some may not. Some may benefit more based on their family history, their heart risk factors. Others will not. So going to your healthcare professional, talking to people who you trust, who are giving fact-based advice in menopause space, put all that knowledge together, look at your risk factors, and take the right decision. There are lots of resources to help you. That's my message out there. And that's the message from IMS, BMS, all the health bodies, including Amantha, who is doing these wonderful videos, is seek help. It doesn't mean you have to take XYZ intervention. Just being aware, making sure you're doing the right changes in your day-to-day life, and if required, an intervention like HRT or non-HRT intervention, that is critical. Just the last point before we finish, Amantha, research. If you get a chance to participate in research, especially if you're non-Caucasian, other ethnicity, Asian, African, Chinese, any other ethnicity, there are some research projects which will happen from now on. We want you to come forward and participate because there is lack of research data specifically about heart disease and many other conditions related to menopause in the non-common ethnic population. So if you can participate, please do join studies. And for people who are interested in research or can provide funding, do support menopause-related charities or menopause-related research projects, because we really need key data during 45 to 75 to better understand what happens at this stage and how best we can use hormonal, non-hormonal approaches. Thank you.
Well said, well said. So where specifically, because I know lots of corporate companies have my videos on their dashboards, where specifically can people go if they want to assist in funding for research? Or if, I mean, is it better for them to get in touch with you, or is there somewhere they should be channeling their efforts?
Well, I think it's usually the BMS, the IMS. If they want to get in touch with us at UCLH, or there are plenty of other tertiary hospitals running research studies, that would be Imperial, Guy's, and of course, there are plenty of tertiary centers in Scotland, England, and across Wales and Northern Ireland. Try and, if you get an opportunity or somebody comes to you with a request for funding, please do fund menopause-related research. That's my
Definitely. Plea. And put menopause, the Menopause Research and Education Fund on your list. You're on my resources anyway, so we'll make sure that people get that. So for now, Vikram, how can people know more about you? We know you're on LinkedIn, so I'll tag you here on LinkedIn, and people can get in contact with you. What's the best way to follow what you do or to know more about your work?
I guess it's the LinkedIn is the best place. I do tweet. Not as much as LinkedIn, but I do tweet from time to time.
Do you?
I'm on Instagram. So I think social media is perhaps the best, easiest way to follow any work. So I must say I'm blessed by people, a fantastic team at UCLH, as well as in my private healthcare where I work, who do loads of things for me. So all that I do on social media is only possible because of them and my family, who look after me when I'm busy. So not taking anything.
Yes, so brilliant. Vikram has the most amazing Instagram account. So we'll put all of the details that we can put down for you, Vikram. But for now, thank you so much for giving your time to this very, very important topic. And hopefully we should do some more of these chats. But thank you, Vikram.
Thank you so much, Amantha. It was a pleasure. Thank you.